The Broad Perspective Network is not responsible for the content of the following program. Good morning, everyone. Welcome to The Broad Perspective on the Broad Perspective Network. We're glad you're with us today. I'm Vivian Kamori.
I'm Greg Barnes.
And I'm Laura Felice.
And we are going to have a really fun and interesting show for you today. Joining us all the way from Colorado are two medical doctors, Dr. Marsha K and Dr. Kathleen Connell. These women, I am so grateful. I am so impressed. I just think that you guys should be nominated for a Nobel Prize or something with your research. This Yale study is really interesting. I've had a lot of fun reading it, and I've learned an awful lot, ladies. And thank you so much for joining us on our show today. These ladies are urogynecologists. Did I say that right?
That's correct.
That's a new field. It was a term I had not previously heard of or known of, and I think it's a very interesting, and I think it's a fairly new field, isn't it? This specialty?
Relatively new. It's been around probably since the 1970s. It really took off, starting it up in the 80s, and by 2000 there were 10 3-year fellowship approved programs in the country, meaning that it was formalized by the American Board of OBGYN as a recognized fellowship. And now there's over 40 in the country, so it's really taking off.
Really? Well, this is exciting. It's interesting. And I want to welcome you to the show. We're going to be talking about female sexual dysfunction. This is not a topic you hear much about, even though it is a topic that has existed forever and is it's a huge problem for so many women, but it's just never talked about. And you ladies are tackling it, and you're coming up with solutions and things that make it better. And I'm very excited to talk about that. So once again, welcome to the show. I know that you are at the University of Denver. This is where you're practicing at the Denver Hospital. Is that correct?
Yep.
Cool. I have a connection with the University of Denver School of Law. Back in from back in the 80s, late 80s. I was on their their panel to evaluate whether or not to rewrite the feasibility of rewriting the Constitution for the state of Colorado.
Wow,
yeah.
That's very impressive.
Yeah, but we decided not to. Anyway, so how many women? When we started talking about this, and we said that many women are dealing with sexual dysfunction. What do you see as numbers? What has your research said to you as far as numbers go?
Well, when you look at most of the literature, it suggests that about 40 to 50% of women are suffering with these complaints. The complaints are manyfold. There's, desire dysfunction, where people just don't have a desire to engage. There's arousal dysfunction, where they have difficulty becoming aroused, the physical difficulty becoming aroused. Orgasmic dysfunction, which, as the name sort of implies, they have failure or difficulty achieving an orgasm. And then pain dysfunction, where they have pain when they're experiencing intercourse. And when you put all those together, about 48% of women suffer from at least one of those different conditions.
Right. Now, I know in the literature that I've read that and doing research for this show, there's a lot of different things that can contribute to any one of these that you just mentioned, from childbirth to physical trauma, and I think those are probably the two biggest ones that affect women. Are there others that you've found to be contributory factors?
I think that when you talk about menopause, when women go into menopause, they have decreased vaginal secretions, and so they can experience vaginal dryness, which may contribute to them having some sexual dysfunction.
Mm-hmm. Now, go ahead. I'm sorry, I didn't mean to interrupt.
Actually, oh no, that's okay. A lot of the previous studies were trying to see if Viagra would work, and although there's some limited success, it hasn't been the magic bullet the way it's been for men. And that's what started Dr. Guess and I looking at neurological components of female sexual dysfunction, which hadn't really been looked at. So previously we looked at just genital sensation, looking at if women could sense the difference between touch or vibration sensation. on the external genital region.
Mm-hmm.
And we found that women do have a difference when they do have these complaints, and that aging, menopause, and childbirth affect the nerve function. They're some of the confounding factors.
Now, you said that you were looking at whether there was a difference between touch and what we say, mechanical stimulation.
Mm-hmm.
And that is what your research was set out to discover. Is that correct? That's what you were trying to determine with the study that you did there at Yale, the Yale study?
Or we actually did an earlier study where we looked at women who reported having sexual dysfunction and women who said they did not have sexual dysfunction. And with that study, we actually looked at the sensations of those women and noted that there was a difference in sensory function in the genital region with people who reported sexual dysfunction. So when we did this most recent study, we looked as an outcome. We said, well, if there's already thought to be some kind of sensation deficit, if we use a tool to treat sexual dysfunction, will it impact the sensation in the genital region? And we actually found that it did. It improved it significantly for women over time.
Yeah, that's what I was noticing in this information. To me, it seems like it's new research, new study, and yet, and I didn't go back and look at Masters and Johnson and the Kinsey reports and all that to see if there had been much research done at that time. So to me, it seems like what you guys are doing is much more cutting edge, but maybe I'm wrong on that. Did you take into consideration any of the previous studies, such as the Kinsey report or Masters and Johnson or any of that?
Well, Masters and Johnson, they were known for defining the sexual phases of, desire, arousal, climax, and then resolution. What we were looking at, we were aiming to see if, like what Dr. Getz said, if there's actually a neurological component, because many people have studied psychological components and all these things. It's a complex condition, so there are many factors that play in. It's not just neurological, it's not just psychological, it's not just having, estrogenic changes that happen from menopause. So that's what makes female sexual function much harder to treat, and especially since there are different ways that women can present with sexual dysfunction. Like Dr. Guest mentioned before, desire is different than orgasmic dysfunction. So they tend to get thrown into one big category, but I think we really need to sort of break it down, and there's probably overlying factors, but there's probably more specific ways that we could treat. So we were sort of focusing in on neurologic function, because the pudendal nerve is a nerve that innervates our pelvic floor muscles, the bladder, urethra, vagina, both for sensory and motor function of these areas. And it can get stretched by 20% of its length during childbirth. And although you do get recovery of the nerve, not everyone probably recovers as well as we would hope. And so that's why we decided to look in this area specifically.
Wow, very, very interesting.
And a lot of these different, newer data, Masters and Johnson's data was outstanding and really getting us to a point of trying to understand these conditions. But newer data is suggesting that there's a lot of overlap to these conditions. For instance, to develop arousal, there has to be some form of desire. So these aren't necessarily isolated conditions. We specifically chose sort of the physiological condition of arousal and orgasm because they appear more physiologic. With arousal, obviously, there's certain things that can happen during the time of arousal that are physiological conditions, including the idea of developing lubrication to the genital region. And during orgasm, there's a physiological response to sensation and to the activity of sexual activity. And so we felt that if we focused on those two specific areas of sexual dysfunction, we may be able to better understand those specific things if we use some kind of treatment, use a treatment for dysfunction. We could look at those and have some sort of objective findings to determine whether or not people are truly responding.
Absolutely. I know, Greg, you wanted to ask a question. Go for it.
I did. Being the outsider looking in and kind of having a little bit of a medical background myself, I find the biggest challenge in what your work is doing is separating the physiological effects or possibilities from the psychological effects or possibilities. And can you expand a little bit on how you separated the two, and which one did you end up becoming a determining factor on your choice in creating the solution?
I think you're sort of leading into what I was trying to explain previously in the concept that you are absolutely right. The psychological components will definitely impact the physiological components.
Mm-hmm.
But at the end of the day, the question is, can you achieve the physiological components? So regardless of what's feeding into it, our goal was just to see, can we overcome the problem such that you could achieve the physiological outcome? For instance, can you achieve an orgasm? And our study showed that regardless of how you came to have sexual dysfunction, and it could possibly have been influenced by psychological issues that happened in your life or during your lifetime, but what we did show that is regardless of how you came to get to the position that you were in, that you were no longer able to achieve orgasm or get aroused with intercourse, you were able to overcome it by utilizing this device.
Exactly, and which brings us to the device, because I know that this has been one of the focal points of your research was a stimulation device. They go by a lot of different names in the general world, but it's called the arousalator. Am I saying that correctly?
That is correct.
And more commonly known perhaps as a vibrator, or it's an external device that a woman can use. And that is the basis of some of the Yale study anyway, the stimulation device on sexual function and genital sensation. And I found that all very interesting. Now I know you use it called GVSD, genital vibratory stimulation device, GVSD. The common word is vibrator. I don't know what else to say.
Well, the reason we actually use that term is because we wanted to clarify that every vibrator clearly is made differently.
Sure.
And the makers of this particular device purposely looked at the motors of other vibrators, and their goal was specifically to develop something that was somewhat different. And when we say different, we're referencing the fact that many vibrators under pressure, they stop working because of the way the motor is designed.
Okay.
And because they go sort of back and forth. This motor has more of an oscillating mechanism or tool in it that allows it to continue moving under pressure because it finds the path of least resistance by going in a circular pattern.
Okay, very interesting. So did you have anything to do with the design or the attachments or anything, or they were already in place and you did your research and figured this would be the best one to experiment with?
So we actually were fortunate that this company was willing to take the risk to do a study because we could have found negative results. So as junior faculty, it is hard to get research funded at NIH, and you always need preliminary data. So we were fortunate that this company would give us the materials that we could use so that we could give these vibrator or arousal to patients for free. Dr. Guess and I don't have any financial conflict of interest. We don't make any money with, we're not advertising this. We were just needed a device to study women with because our original study showed that neurologic function was decreased in these women with sexual dysfunction. So that's how it sort of started. We were just fortunate to find a sponsor. And then they do have different attachments that come with the arousalator. So we just chose ones that to us looked like it looked soft and smooth and that may be beneficial.
Okay. I find that quite interesting. Go ahead, Laura.
Yeah, because I didn't know that there was going to be a drawing or a photograph of it. So when I was reading the paperwork and I came across what the devices look like, I was quite surprised. It did not fit any image I had preconceived in my mind.
Okay. So. Yeah, there were several different attachments that a person could choose. Now, did you on your subjects, did you let them have free reign of the attachments they could use, or were they only allowed to use certain ones?
there were 2 attachments that they could use, that they could choose from. We didn't want to
Okay.
be, you know,
Sure.
totally demanding on them, but we figured if we had too many attachments, then you don't know, is it one attachment is better than another? So we just chose 2 that looked soft and that could be standardized for the study.
Okay.
And at the end of the study, we actually gave them all the other attachments, and obviously they could choose and select which ones they wanted to use later on. But like she said, we wanted to keep it standardized. And we actually asked, I think there were 7 of us who were in a room, and we sort of said which ones seemed like they would look the safest and the most comfortable, and we picked 2 of the group.
Okay, very good.
Okay, good.
We're going to take a break. We'll be right back with more of the broad perspective and our visit with Dr. Marsha K and Dr. Kathleen Connell. So stay tuned. We'll be right back.
Hello, I am His Majesty the Soul, King of Mauritius, and I invite you to help me build the world's planetary egg, an ecological geophysical galleon. It's approximately 180 acres, and it is home to 3,000 researchers from around the world. It is the world's first sovereign planetary independent jurisdiction that has the capability of advancing and progressing and fast-tracking every aspect of innovation, helping us redefine what it means to be human in a new world. So check out our website. It's www.mauricii.com. MORACEAE.com. I look forward to seeing you, and please contribute, donate to the GoFundMe page. I look forward to meeting you, and let's build the planetary egg. Thank you.
Welcome back to The Broad Perspective on the Broad Perspective Network. I'm Vivian Kamori.
And this is Greg Barnes.
And I'm Laura Felice.
And we're continuing our discussion with doctors Marsha K and Kathleen Connell and about female sexual dysfunction and about how to overcome this, the studies that they've done, the research that they've done, and the solutions that they have found. And this is a very interesting discussion. I think that the research that you've done is going to, and as this becomes more and more known, this is one of the things I was thinking, okay, and this is going off just a little bit. On the news every night, there is some new study that they're talking about. It might be coffee causes heart disease or something, and then the next night it'll be some new study done at this university says coffee fixes heart disease, and there's just constantly something on the news of a new study that's been released that shows something, and I think that this study needs to be released in the media. Have you attempted that? Have you do you know why it hasn't? I just feel like this is so important that people understand that there are solutions to this problem, and that needs to be looked at, and I think that the media needs to get a hold of this, and they haven't.
Yeah, I think it speaks to the topic,
Yeah.
because I think it is sort of taboo. I was interviewed by some TV, and sometimes it's acceptable, and other times it's not that they think that we're horrible people or the studies are horrible, but they're afraid that if for families airing that it's not going to be appropriate. And I think it just speaks to the topic matter that we're studying. And I hate to say it, but probably because it's the female world.
Thank
if it were
you.
Viagra, it would probably be all over town.
That's exactly.
I agree.
Yeah, that's exactly what my thought was. If this was a study on men, it would be, because we see commercials prime time all day long about Viagra and about Cialis and all these male enhancements, but let it be about a woman, and we can't do that.
Well, I
We
think
totally agree. We also, I'm sorry, one of the things I just wanted, we also thought it was very interesting because when we were doing this study, we got a lot of, commentary, as you always get. And, people would say, well, who's participating in this study? And, we were pleasantly surprised that the vast majority of women were people in stable relationships. Husbands would sometimes come with their wives, and they could have been in relationships for 3 to 7 years and had never had a pleasurable sexual experience. And they participated in the study because they were happy in their relationship, but didn't really know where to go from there. And I think that this belief that, this type of person will participate, or this is the type of person who's experiencing this, is actually false. In fact, many different types of people experience sexual dysfunction, including, the classic person who you don't think experiences it. And so for us, that was very enlightening and actually made us even, more excited to participate in this type of study and make sure that these people's voices could be heard.
Thank you. Yes. Go ahead.
I was just going to speak to Vivian's question that about, this airing in the media or being presented. And I think you guys haven't gotten to that stage yet because the product is not ready to be commercialized yet. And so once the product becomes commercialized, then that opens the door, or at least in the infomercial realm, of being able to discuss all of this, on the late night infomercials.
There has to be money to be made.
The product's got to be there to go along with it. They're not going to just allow this to air just for the sake of discussion, but when there's money involved, of course, then now you got their ear.
Okay. Well, that's another interesting angle I didn't think about. Yeah. Okay.
Yeah.
But I think that products get commercialized because funding goes into them to research the concept and the idea. So you have to take a step back and say, where's the funding going? And is it going and being directed appropriately to female sexual dysfunction, so that we can do these studies and identify these women and give these people a place to be studied.
Right.
Because if we're not paying for these studies to be done to ensure that women can be evaluated, then we're never going to have a product that reaches the market in the way that you're describing.
Do you think that there is a possibility that males might feel threatened or their egos bruised because their partner, this is for people who are in a relationship, in a heterosexual relationship, might not be sexually fulfilled with orgasm or what have you, that the men might feel threatened because, or not inadequate, perhaps I should say, because the woman is not achieving sexual fulfillment. Did I say that right?
That wasn't necessarily our experience.
Okay.
I'm sure there are people out there who do. We found that there was a lot of guilt on both sides. We found that husbands felt guilty or felt, saddened that they couldn't provide, less threatened, but almost saddened. And the women did feel guilty that they weren't able to provide that experience to their husbands. And so we saw it more as a feeling of guilt, and obviously personal inadequacy by some of the women. But in many of our instances, the relationship was there, so they were actually pretty supportive of each other, but just couldn't understand how and what was preventing them from getting over that hump of the condition that they were dealing with.
Very interesting.
And that makes a lot of sense because, like you said, the surprising results that you got, or the surprising participation that you got, doesn't necessarily represent the people that wouldn't show up for the study, because those are the people that probably are having the relationship problems as a result of the dysfunction on either side of the fence. And
right.
And so in a sense it's kind of skewed, but it's still going to represent the general population because the dysfunction is the dysfunction.
I think you're correct, absolutely correct. And you're right in the fact that it's probably skewed towards people who were in healthier relationships, obviously, in more supportive relationships in many ways. But to know that, that there are a large group of those women who exist who still aren't having the normal function goes back to your original question about how do we know it's not psychological, right? These were people who were in healthy, or at least healthy appearing relationships, and we're still having the dysfunction, and we're able to overcome this dysfunction with this tool.
Okay, I have another question. In your research, was there a difference between? Do you find that heterosexual women, as opposed to lesbian women, have greater or lesser sexual dysfunction? Because this is my assumption, because I don't know for a fact, but my assumption is that lesbian women would use more devices than the heterosexual women. And did you take into account, or did you have both represented in your survey? And I think I read that you did. But was there?
We did, but the numbers weren't large enough.
Okay.
We absolutely opened it up to everyone. I think when you looked at the percentage,
Uh-huh.
it was by and away a larger percentage of heterosexual women who participated, and we did not have enough to tease out the individual responses between the two groups.
Okay, so the study aside, in your private practice, do you find that there are gay women or lesbian women that do still have female sexual dysfunction?
Absolutely.
Okay.
I think sexual dysfunction is across the board for anyone.
Okay, that's what I wanted to know. Okay, thank you for
Absolutely.
for that.
Yes.
I appreciate it. Okay, so then getting back to that, the vibrator, the what, GVSD? Did I say that right?
GVSD,
GVSD. Do you think that is going to change this whole? I think it will. If women can understand that if they are experiencing female sexual dysfunction, and that they can at least give this a try, and that it could make things different and better, I think it's going to be a huge thing for women.
I think so, and I think the key is, as urogynecologists, we see many people with not only sexual dysfunction, but pelvic floor dysfunction and urinary incontinence. And I think a lot goes back to preventative medicine, where we're not addressing people right after vaginal delivery, difficult deliveries. And I think that we probably need to be doing more pelvic floor therapy with electrical stimulation to regenerate those nerves, and probably using more of these genital vibratory devices for those who are having sexual dysfunction earlier in life.
Now, do you think that these devices would also assist in urinary? Because I know a lot of people I have a lot of elderly friends that have this issue with urinary incontinence as they get older. This would help with. Have you found that it helps with urinary incontinence?
Absolutely.
Really?
We use a lot of neuromodulating tools to treat urinary incontinence in women. And so, exactly what you're saying, there are definitely benefits to neuromodulation in urinary incontinence and other pelvic floor disorders for women.
Oh my goodness! I can't wait to share that with friends.
Yeah.
Seriously.
Well, my business mind just went off on this whole situation, and I can easily see this becoming a post-delivery therapy, which translates into insurance dollars based on your information, because that's their goal, is to produce procedures that are going to create money for them. And now they have a tool to create this new procedure by your information.
There are neuromodulators, as I mentioned, that we actually do use currently for women with urinary incontinence who have both postpartum and later in life. I think the important part of the sexual dysfunction piece is the stigmas that are attached to these devices. As you know, many of these devices exist in what people call, quote unquote, sex stores. And they're considered, those people go to those stores to get that device. And what we really wanted to do here was identify some sort of objective outcome and finding for women who are suffering with sexual dysfunction. And because we did that, what we're hoping is that people would stop looking at these as sex toys and recognize them as in their ability to impact the neurological sensation in the genital region, which may in fact improve sexual function for some women.
This is so incredible. So now, I'm kind of going back, but would the same device that would be used for sexual stimulation be effective in treating the pelvic floor and urinary incontinence? Or do they have to get something completely different and use it completely differently?
No, that's a good research question, and we've wondered that ourselves. Anecdotally, we have patients that use genital vibratory devices and swear by them. So I think it probably could very well impact their pelvic floor function. And I think any kind of stimulation of the nerves to get the muscles to contract, right, which is what happens with orgasm, I think is healthy for the pelvic floor.
So what's it going to take to get you to do that study? Cold hard cash?
Sponsors.
Yes,
Sponsors.
all you listeners out there. Send those texts.
Do have a research fund
Okay.
for our division.
The section of urogynecology at the University of Colorado. It
Okay.
is tax deductible, I believe, or some kind of something. It's a donation, so
Which purely goes to research. We have a research
absolutely.
fund. So really, it's like we said, we were very fortunate and thrilled that a company did sponsor us to do this preliminary study.
Yes.
What we'd really like to do is take it to the next level on a larger scale, and perhaps even looking at other devices so that it could be more generalizable to across the population. And like the things we talked about, heterosexual, homosexual, all the populations, to see who these devices can benefit best.
Okay, so what was the name of that fund again? University Research Fund, University of Colorado.
It's a sexual.
Yeah, we have a website. It's called urogyn.coloradowomen'shealth.com. And on there we do have one of the tabs talks about our research. And if anybody was interested in donating, we'd be more than thrilled and very appreciative for that support. And we would make sure it goes into good research.
Oh, that's awesome.
Can you give us that website one
And
more
that
time,
website
please?
is also a great tool for people because it has a lot of literature and information both about urinary
Great.
incontinence, which is one of the things you brought up, as well as pelvic organ prolapse and some of the other defecatory disorders that some of the women deal with that we work with regularly.
Right.
And there's a specific button on that site that says you can donate. It says if you go under there are a bunch of different headings, and under the one that says what we do, there's a research button you can click, and it says donate to CU Urogynecology. And so if they go on there and hit that button, we are happy to accept those funds and hope that people stay as excited about our research as you are, so that we can continue to advance this field. We
Okay.
find that it's very, very important for women, and we love what we do and do our best to try to help as many women as possible.
We'll include this in the archive summary. So we're going to take a break. We'll be back because we're going to ask you to reiterate that website again when we come back. We'll be back with more of the broad perspective and our visits with Dr. Guess and Dr. Connell in just a moment. Stay tuned.
The 12th hour.
A show literally about everything.
Everything.
A candid discussion between friends about their different perspectives on what they think may be going on.
Or what is not going on.
With so many different areas of information being given out, we attempt to put together the puzzle pieces to create the
broad perspective of the whole picture.
Welcome back to the Broad Perspective on the Broad Perspective Network. I'm Vivian Kamori.
I'm Greg Barnes.
And I'm Laura Felice.
And we're continuing this very, very, very interesting discussion with two of our medical doctor friends that from the University of Colorado Medical Hospital, and it is Dr. Kathleen Connell and Dr. Marsha Guess, and this is so enlightening. I just feel like I'm learning so much. I remember back when I turned 40, my husband had a surprise party for me, and I wrote a letter of thank you and to everybody, a handwritten letter, but I also included a little longer form letter, and I just remember saying the title of the thing was "Why Turning 40 Doesn't Suck," and so I listed all these wonderful things about getting older and having wisdom, and that, believe me, turning 40, that was a long time ago. But I remember saying at the time, I can still laugh at bladder control jokes, just not too hard.
Wow. Well, I've got a question that goes back into the technical aspects of it. Is there a problem with overusage of this product? Because I just, being that ignorant guy in the room, I look back and I think, you talked about that difference in sensation between touch and vibration. And to me, I just innately come to the conclusion that if there's vibration all the time, then the body will desensitize to touch. And so I'm wondering now, is there a possibility of overusage for this product?
I think there can be for anything. Obviously, you can, if you're overstimulating, you could potentially chafe the area.
But the idea behind, their motor and their concepts was that was one of the things that they looked into. And by finding this sort of path of least resistance, I think the idea is that the motor doesn't stay in one place and cause that typical damage that you may get from other devices. Not being the person who designed the motor and fully comprehending the mechanics of the motor, I did ask that question myself when we were starting this research product, because when you start a research project, you also have to consent patients and you have to let them know what those risks include. And I know that they spend a lot of time trying to make sure that motor worked functionally to avoid that. I will tell you that the motor was actually designed by one of the first persons to develop the electric toothbrush. And I say that because we now use that sort of oscillating toothbrush that everyone has on their bathroom shelf. And so the argument would be, if it were true, then we would probably be doing more damage to our teeth than good. So they do have sort of expertise in understanding pressure and mechanics in a motor. And that was one of the reasons we actually selected this product over other products, because we wanted to make sure we weren't going to cause women more harm than good.
So, did your study show, or did you even look at this, does your device, which improves sensation of vibratory touch, translate to
Physical touch?
Physical touch.
Oh, okay.
I mean,
Yeah, so there were two outcome measures. One was, were they subjectively experiencing more pleasure and orgasm, where they were documenting their experiences, and then objectively we looked at their sensations. So we have a device that can test the pudendal nerve sensation. So it's a probe, it sits right by the skin, and at first when you place it gently against the skin, that's just touch. But then a motor will start to make it vibrate slowly over time, in a computerized system. And then the patient will click with a mouse when they feel the difference between static touch, like just pressure, versus vibratory sensation. And the more vibration you have, if it takes you longer to feel, that means your nerves aren't sensing it. People who sense it right away have better nerve function. So we actually had an objective outcome measure too, to say, are the nerves what are the nerves, when are they sensing it, and how are the nerves functioning?
This is such an interesting subject. Now, one of the things that popped into my head was they say that the most erogenous zone is between our ears, our brain. And so I would think that when we talk about physical touch or the electronic stimulation, unless we're in fantasy land with our boyfriend on batteries, or Bob is my girlfriend, so eloquently calls her friend, then the thing is, if you're having physical touch, there's some sort of emotional connection. There is some sort of mental stimulation. There is an intimacy that you're not going to have with Bob, or with the more appropriate and less juvenile title of GVSD. But you don't have the emotional stimulation between your brain. Am I making any sense, or am I just rattling on?
Well, I think, at least it sounds like you're talking about, we did have, the participants in our study actually used both the device as well as stimulation from their partners. And we didn't tell them how to do it or what to do. And what we found, that over time, women use the device less, but continue to have the same responses to their sexual activities. So it suggests that if we can increase or enhance that sensation in the genital region, we may be able to provide people with more long-term success with having partner intimacy. And so I don't necessarily think you're going to have the device all the time to have that experience. So that speaks to your idea of perhaps it does re-signal what's going on and coming from the brain so that they can have positive experiences even when they're not using the device.
Or they're feeling better about themselves and more confident. That's always been shown to be factors in sexual function as well. So if they feel like now they can succeed, I think it's a positive reinforcement that play on each other.
Wow, you know what I just heard was that this device is actually a healing device as opposed to a dependent device.
There you go.
And
that was really important. Yes, absolutely. That was one of our most important findings, and we were very pleasantly surprised to find that.
Well, I'm shocked at it too because that's why the question came up about overusage, is because I was beginning to sense dependency on this device, whereas what you've just said clearly shows that your findings, you were creating healing. You were rehabilitating the nerves that were damaged, and everything's working naturally on its own after a certain period of time.
That's what I got.
Wonderful.
That's what I got from that Yale study, because if I remember the outcome at the very end, the women that participated in the study, they found that their sex life was so much more comfortable and much more enhanced that a lot of them did not necessarily continue to use it much at all, but that their life in general was just better. And so it was an enhancer from the standpoint of it made their physical body heal. And in that regards, it was a much better tool.
Here's a Christmas gift for all your female friends.
There you go. I wonder if we can get bulk discounts, Oh my goodness. Okay. One of the things I wanted to ask you, now I noticed with the arousalator, it says a long cord. So is it an electric device or is it run on batteries?
It's an electric device, and I'll tell you, when we first got it, we both looked at each other and said, what in Sam's Hill? However, we actually were pleasantly, again, surprised because the participants loved it. Many of these participants had tried other devices, and they would say things like, when it was by my bedside on a day that, we would try it, the batteries were dead. Or,
right.
That particular day, it wasn't available because it was dying. And it's a pretty long cord. And they said because it was a cord, there was never a time when we wanted to use it or we went to grab for it that we couldn't use it because there was a cord on it.
Okay.
Right. And they made it specifically long so that it would reach wherever people needed it to go.
Sure.
In terms of their room and the bed.
That's different.
Gotcha. And a nearby outlet. Yeah, I gotcha.
I still think that the USB cord is a possibility with a very nice battery. The batteries are different now than they used to be. Instead of a couple double C batteries or something, I could see a new ion lithium battery with a USB plug to it that, it has the bells and whistles like our other devices. So you can almost prepare or don't have to necessarily be prepared, but you'll be fine.
I absolutely agree. I totally agree. And, obviously times have changed a little since we started the study, so I could absolutely see them even trying to remanufacture it with that idea in mind.
Absolutely. At what point do you prescribe this? By the way, if you prescribe it, is it tax deductible? And at what point do you do this with your patients when they come in and they mention that they're having an issue, or that that is there a checklist that you go down and say, oh, yep, okay, yes, definitely, they could use this?
Do you have a history of this?
Yes.
Everybody has those forms when they see a doctor.
Oh, patient history forms,
Yeah.
which would isolate if they were a candidate for something like this. That's what you're trying to say.
Right.
So as you guys know, we're actually urogynecologists, and so as urogynecologists, we also deal with urinary incontinence, pelvic organ prolapse, and defecatory issues. And about 1 in 4 women actually experience these conditions, which means it's very, very common. And those issues also have to be tackled. So as a practice, we don't focus specifically on just women with sexual dysfunction. Most of the people referred into our practice are dealing with urinary incontinence or pelvic organ prolapse. But with that, a lot of those women actually have sexual dysfunction. And that was one of the sort of prompting things that made us start studying sexual dysfunction, because we were seeing so many women with both of these combined conditions. We have several women who are menopausal, and those women we may prescribe, hormones and things like that that might help with them. But we do have a fair number of women who deal with sexual dysfunction on other levels, and when they report it to us, we do tell them about the study that we did, and tell them based on that study that this is available. We did not study, millions of women, and it's not generalizable to everyone, but it is worth trying, in my opinion. If it works, great, and if it doesn't, so be it. At this point, there are very few treatment options for these women. So oftentimes we will let them know about this device as a treatment option for them if they are reporting some sort of arousal or orgasmic dysfunction.
Unfortunately, because it hasn't been FDA approved for that indication, it's not covered by insurance companies. And so I think until we do those larger trials, we're really going to be limited in, it's sort of like what we call an off-label use of a device. But I certainly think it's a great recommendation, and we do recommend stimulatory devices for a lot of our patients.
So we need to lead a crusade on that then as well, huh?
We love it.
Okay.
Thank you.
Yeah, well,
we've
that's significant.
We've had quite a crusade with the advent of, what was her name, June Allen, and the first commercials for Depends. But the one, even though we kind of laugh about that, I mean, it's much more common now. You see commercials, but nobody talks about fecal incontinence, and which is actually, I think, more common than people think after childbirth, vaginal delivery, childbirth. Not just urinary incontinence.
Yeah, all these things are issues.
And we like to tell people, although you led a crusade and Depends are okay for some women, there are a lot of women out there who we can treat. We can actually get them out of Depends if they just come in and be seen. And that's one of the things that we really try to push for people to stop telling people there's not a treatment option or that it's a normal part of aging. Right. These things aren't normal, and they can be treated. They're just common, right?
And there are urogynecologists out there. I mean, even at the beginning of the show, you said you hadn't heard of a urogynecologist. So we're thrilled just the fact that you have us on the air and people can know that there are specialists in their area all over the country that can help them.
Absolutely, absolutely. We're going to take a break because I'll tell you what, I could talk to you guys all day, but unfortunately we've got this time constraint thing. We have to take a break. We'll be back with the concluding segment of The Broad Perspective. Stay tuned. We'll be right back with more of female sexual dysfunction and the visit with our two wonderful doctors. We'll be right back.
BPN. Join the awakening.
The Broad Perspective Network is a portal designed to reveal a new perspective and reality to those who wish to know the truth about the world we live in and our role in it.
BPN. See beyond the illusion.
Welcome back to The Broad Perspective on the Broad Perspective Network. I'm Vivian Kamori.
I'm Greg Barnes.
And I'm Laura Felice.
And this is the last segment of this discussion, which has just been so helpful and so informative and so necessary. And our two doctors today that are spending time with us and sharing this information is Dr. Marsha K and also Dr. Kathleen Connell. They're medical doctors at the University of Colorado Hospital there in Denver, Colorado. And boy, we are so grateful. I want to at least reiterate the website that people can go and get information and also donate, which we encourage people to do. We need more research in this department. And if you'd be so kind, tell us once again what that website is.
Sure, it's urogyn.coloradowomenshealth.com. That's a mouthful, so I'll spell it out. It's UROGYN dot COLORADO and then womenshealth.com.
Okay. And right on. So, and all the information that we've talked about today is most likely on this website, correct?
Yes.
Absolutely.
Okay. All
Yes.
right. All right. So we're going
I
to.
really encourage people to go into, there's a specific link for patients
Okay.
that gives them patient information about things like urinary incontinence, pelvic organ prolapse, as well as a what we do link that talks about the research that we do, but also what is a urogynecologist and what do we do.
And how
Okay.
to find a women's health specialist.
Okay. Okay. Very good. Thank
Well,
you.
I
for
think this is going to be a topic of discussion around this neighborhood for a while.
that. Indeed. Indeed, it is.
We hope so. Spread the word
Yes.
that there's help there
Yes.
for pelvic floor disorders.
Yes.
Now, I wanted to get this in there because I know that there was a common belief amongst women that if we do Kegel exercises after we give birth, if we just do these Kegels, that everything's going to be just fine. It's going to fix everything, and we're not going to have any problems with sexual satisfaction or with urinary incontinence or any of this. And I read recently, and I read constantly, so I've seen just about every study that says one thing and then contradicts itself with the next study, but said that Kegels were not that effective. They're finding that Kegels were not that effective with all of this. What's your opinion on that?
So what we find when we examine patients is that they often have trouble doing the Kegel exercises.
Mm-hmm.
And if you can't do it, and there have been studies showing that there is a difference when you go to physical therapy versus sending somebody home with written instructions on how to do the Kegel exercises. So first and foremost, I think people do have some neurological deficits sometimes that can persist. Not for everybody, but there's probably a subgroup of women who probably really do need that early intervention of physical therapy shortly after childbirth. And then I think that the losing weight can also help. Dr. Guest can talk about a study that she actually participated in.
So I worked with a woman from China, actually was a visiting scholar, and we showed that if you get back to your baseline weight after delivery, you are less likely to have pelvic organ prolapse, so that pelvic floor sort of hanging down. It would return and restore itself to its normal position. You would more likely to have restore itself to its normal position if you went back to your baseline weight. And as you know, particularly here in the U.S., weight is a problem for many women.
Mm-hmm.
So we do encourage people not only it's not just an isolated thing. I do my Kegels and my Kegels will prevent these things. It's multifactorial. So doing Kegels is absolutely effective for many women if they do them correctly, and often that does require a physical therapist. But looking at other things like heavy lifting, avoiding chronic coughing, getting back to your normal weight, avoiding tobacco, which affects your connective tissue altogether. And so if you put a lot of different factors together, you might see that these Kegels are effective. We're just not doing them correctly, and we're not also modifying other factors that might contribute to these problems long term.
Okay.
Okay, I've got a question on the subject, being that stupid guy in the room again. This is my first time hearing about Kegel exercises. Is this something that's similar to like yoni eggs or something?
Yes, the yoni eggs are placed in the vagina, and that actually forces people to contract those pelvic floor muscles, which that's what the Kegel exercise is. So they're helpful. They're a form of biofeedback where people have a sensation of something to hold against so that they know that they're contracting those muscles correctly. And Kegel exercises are important for both men and women because those are the muscles that keep our urethra and rectum closed when we're at rest. So it's good for everybody.
Okay, so you would advise people to continue to do Kegel exercises then, correct?
Absolutely.
Yes. And
Okay.
if it's
Men
not
and women.
working, then seek care, because there's going to always be someone who does something and they do it correctly and well, but it's still not working because their damage may be more extensive, and so it doesn't allow the Kegel exercises to work effectively.
Okay. Now, one of the ththings I want to ask you, you're a urogynecologist, which I would assume only treats women. Is there ever an issue with men who have issues with incontinence and all this kind of stuff? Because I know they do, but you don't see men in your practice, or is there another specialty for that?
Yeah, that would fall under urology. So for urogynecologists, we're OBGYN trained.
Okay.
And then we did 3 extra years of subspecialty training. So we don't do obstetrics anymore. We solely do the reconstructive pelvic surgery, but just for women. Urologists, though, would be the appropriate people to see for that for men.
Okay. Thank you for that. Wow. Since we're just about out of time, what is the takeaway? What do you want our listeners to take away from this discussion today? What's the most important thing? Say some of your patients and some of and our listening audience, you want them to remember one thing or two. What would that be?
That pelvic floor disorders, urinary incontinence, pelvic organ prolapse, sexual dysfunction, fecal incontinence, as she mentioned, are very common disorders, but there are treatments out there that can significantly improve women's quality of life. Don't suffer in silence. Get out there, tell someone, and identify those treatments that are available for you. And if you have sexual dysfunction, that treatment may be the arousalator.
Okay, but the arousalator might also treat some of these other things, which is yet to be determined, correct?
Correct.
Okay. Well, I don't know. To me, that would be taking a drug, and having to rely on a substance. That would be my first line of attack, I would think. That's me.
Right.
That's what I don't know. Anytime that you can avoid having to take a substance internally, I would try just about anything else first.
I have to agree, and I think one of the things we liked, as I mentioned before, is that what we saw is if you use the arousalator, it may be a treatment that can impact you long term, so that you don't have to rely on it anymore. And that's not true of most medications. And so I, sort of corroborating what you're saying, I think that we may have identified a treatment that can cause lasting effects without having to ultimately use the device all the time.
Absolutely. Okay, great. This is just now. Okay, now having said all this, the arousalator, I know I think you said manufactured by a Swiss company. How would a person purchase one of these? Do you have any idea? How would go? If I say I want to go buy one today, how would I do that?
It's actually available online.
Okay.
So if you put in the arousalator into Google, it would come up. Yeah, it's been available. It's a European-based company, but they do ship everywhere. And it's been available for at least 10 years, as far as I know. And I believe the underlying company is Advanced Medical Research Group, but it's under the arousalator. If you go online and just type in the arousalator, it will definitely come up.
Okay, and that is spelled EROSCILLATOR. So
Yep.
for people that want to Google that and look it up and go out and buy one. And again, check on group discounts. I'm just saying. I'm a bargain hunter. Okay. So anyway, gosh, this has been so fun, ladies. We really, really, really appreciate your time and your wisdom today, and sharing it with us and sharing it with our listeners. We are eternally grateful. We wish you the very best.
We're just thrilled you're spreading the
Thank
word
you.
so that women know there's help out there for them. It's amazing. So thank you.
We will.
We're very, very happy to do it, and we're just grateful for you. We're grateful for you and what you're doing and the research and the wisdom that you're providing. So thank you so much.
And ladies, if I could say real quick, I'm not that stupid guy in the room anymore.
So thank you once again, and we want to tell our listeners, remember, join us same time, same place next week, where it's all perspective. Join us and broaden yours. Thank you for listening.
We hope you've enjoyed today's show. To keep programs like this and other programs on the Broad Perspective Network, go to thebroadperspective.com and click the donate button. We truly appreciate your support.